This patient had right flank pain, hence imaging of the abdomen and pelvis was done to exclude appendicitis. In such clinical history, we need to exclude all acute pathology that can occur on the right, which includes cholecystitis, pyelonephritis, ascending colitis, acute hepatitis, appendicitis, and the most common of all, renal or ureteric calculi. In this case, I can see mild hydroureteronephrosis. Distally, a bright structure is seen causing obstruction in the distal ureter. This is a distal ureter calculus. This CT scan was done for trauma. The patient had a road traffic accident. So on these bone windows, as we scroll from the top, we can see that there's a fracture of the right scapula, which means the mechanism of injury is from the right side. Hence, we need to exclude injuries first on the right side of the body. Scroll down as we look for rib fractures. Look for lumbar transverse process fracture and finally down to the level of the pelvis and sacrum. Did we see any fracture? Change to bone windows and look very closely at the transverse processes of the lumbar vertebral bodies. I have not identified any fracture on the right side. The next step would be to look at midline structures for injuries rather than move to the left side. Midline structures from the odontal peg, vertebral bodies, spinous processes, and the sternum down to the pubic symphysis. In this patient, we can see upper thoracic spinous process fractures. The CT scan was done for trauma. The patient had a road traffic accident. So on these bone windows, we can see that there is a fracture of the right clavicle, which means the mechanism of injury is from the right side. Hence, we need to exclude injuries first on the right side of the body. Scroll down as we look for rib fractures. Look for lumbar transverse process fracture and finally down to the level of the pelvis and sacrum. Did we see any fracture? Change to bone windows and look very closely at the transverse processes of the lumbar vertebral bodies. Yes, there are fractures of the transverse processes of the lone and L2 bodies.
The CT head was done because the patient has loss of vision. Axial images show no infarct, no hemorrhage, and no hydrocephalus. Is there any acute finding? Loss of vision is pretty bad, isn't it? Can't miss any finding here. I see a bulky appearing pituitary fossa. The pituitary region is best seen on coronal and sagittal images. Indeed, there is a large pituitary tumor extending superiorly, compressing the optic chiasma. Very clear cause for vision loss. CT head was done for injury. Clearly, there is a large acute scalp hematoma in the frontal region. No coup or contra coup injuries, no extraaxial hemorrhage. Did you spot anything acute? There's a bright spot in the right sylvian fissure. Look at all planes to confirm the subarachnoid bleed. The Hausenfeld value also confirms it is an acute hemorrhage. This patient has Clostridium difficile colitis. The CT was done to exclude perforation. What do you see in the study? Any abnormal finding? If we scroll down to the region of the sigmoid colon, there is some amount of inflammation. There is no bowel obstruction or ischemia. No pneumoperitoneum is seen. Is there any extraluminal collection? Did you spot it? If we look closely in the region of the sigmoid colon, there's a well-defined extraluminal collection. A fluid level is seen within, and it is seen in close proximity to the sigmoid, suggestive of a diverticular abscess. No fistula or abnormal tracts seen. It's pretty obvious that this abscess has been building up for a while. It's important not to miss this finding because only a radiologist can make this diagnosis. A multidisciplinary discussion about interventional drainage will be needed. This is an interesting study because many young radiologists get excited when they see these images. You should know what this CT head shows just by looking at these axial images. Is it an acute hematoma? Is it an aneurysm? It is a calcified meningioma near the greater wing of sphenoid along the left side. On bone windows, you can see it's broad-based with expansion of adjacent bone. This well-defined extradural lesion shows homogeneous enhancement. The intracranial angiogram also clearly shows the lesion is not an aneurysm arising from the left middle cerebral artery. This lesion has classic meningioma written all over it. A 70-year-old had head injury and a CT head was done. Hopefully you have picked up the right parietal hematoma. Interesting. There is a left parietal acute hematoma as well. Are there acute calvarial fractures? Change to bone windows. Bone windows clearly detect the parietal fractures on both sides, best seen on coronal images. Sometimes you have to wonder the mechanism of injury involved to have these bleeds. These bleeds are likely extradural as they are seen directly beneath the fractures. Neurosurgical referral may be needed in this patient. This infant had a head injury. There is significant scalp swelling in the left parietal region. Can we see an acute bleed? Here there is an acute extraaxial hemorrhage in the left parietal region. Next, we need to look for a calvarial fracture. Bone windows are great to detect fracture. There is a non-displaced fracture of the left parietal calvarium in this infant. Volume rendering is a fantastic tool to help detect fractures too. As we see in this volume rendered image of the skull, it's pretty clear to see a fracture, and it's well differentiated from normal calvarial sutures. Volume rendering can be used along with bone windowing to detect pediatric skull fractures. This CT pulmonary angiogram clearly shows filling defect in the right pulmonary artery due to an embolus. This embolus extends into the segmental branches of middle lobar and right lobar arteries. Easy to see and should not be missed. There is also a tiny filling defect in the left lower lobe artery. This is much harder to detect. It is easy to fall for the satisfaction of search error in radiology. Following a reporting template can help to avoid such errors. The CT head was done following head injury. As you can see, there is a large acute hematoma causing mass effect and midline shift. Subarachnoid hemorrhage and an acute right subdural hematoma is also seen. The subdural bleed is seen extending to the posterior falx and the right tentorium. A good radiologist would be expected to report on all these findings. An exceptional radiologist would have also detected the small acute bleed in the occipital horns of the lateral ventricles. Please share, like, and subscribe. This CT head was done on a patient who has loss of vision. This shouldn't take much time to report. Clearly, there is an acute infarct in the left posterior cerebral artery territory. Also look for thrombus in the left posterior cerebral artery. This infarct is also most likely hemorrhagic. Age-related changes also seen in the CT head. Let's try to find the source of obstruction here. CT abdomen pelvis was done, which shows dilated small bowel loops. Whenever I see a stoma, I always look at this region for a source of obstruction. This patient has no stoma output. Can we see any zone of transition or obstruction at this region? Use all planes and try your best to identify any narrowing or kinking. Track the bowel proximal to any narrowing to see if there is any dilated bowel loops. Track the bowel proximal to any narrowing to see if there is any dilated bowel loops. Here, the narrowing is seen just proximal to the stoma opening. No other complications are noted. As this case demonstrates, it is easier to focus on the most likely source of obstruction rather than tracking each bowel loop. Hope this case was helpful. Please like, share, and subscribe. This patient had a clinical diagnosis of aortic rupture, hence a CT was done to exclude aortic aneurysm. We can clearly see the aorta is normal and there's no aneurysm or retroperitoneal hematoma. So what's the problem here, if any? Can you see any abnormality? Did you spot it? If you picked up the inflamed and bulky appearing pancreatic tail, then you are right. This is clearly acute pancreatitis with peripancreatic fat stranding. No other acute finding is seen. A serum amylase test can be suggested to confirm the diagnosis. Looks like we have another case of bowel obstruction. I can see the transverse colon is collapsed, hence I'm going to start looking from above for the source of obstruction, starting from the gastroesophageal junction and going below. We can see the duodenum is dilated and fluid-filled, proximal jejunum is dilated, and all the way to the right, iliac fossa. A small area of transition or twist is seen, better seen on coronal images. This is clearly the site of obstruction. Distal ileum is collapsed. The large bowel is collapsed as well. No mass lesion was seen. No signs of pneumoperitoneum or bowel ischemia. Notice the patient has had a hysterectomy. Cause of obstruction in this patient is most likely due to adhesions, not uncommon in post-surgical patients. This is a very interesting case. I've seen very few of these in the last couple of years. This patient has very high liver function test. A CT was done to exclude any cause of obstruction. Intrahepatic biliary ductal dilatation is seen. Common bile duct is dilated up to 15 millimeters. If we look distally, we can see an enhancing soft tissue lesion within the middle of the bile duct. This is best seen on the coronal and sagittal images. I think this lesion could be neoplastic as it shows homogeneous enhancement. Also, the obstruction causes back pressure changes, which explains the high liver function values. This patient most likely will require an ERCP. Cholangiocarcinoma is the first differential diagnosis. This patient has left leg pain. MRI of the lumbar spine was done, which clearly shows disc extrusion at L4, L5 level. There is sequestration as well. Comparison with prior study shows that this is a new finding. The extrusion is migrating inferiorly. Impingement on the traversing left L5 nerve root is clearly seen on axial images. This CT scan demonstrates how artifacts can hide underlying pathology. This 7-month-old baby fell with head injury. As we scroll to the top of the head, we see motion artifacts distorting the image. Can we see any intracranial bleed in this study? Not really. A repeat study was done, and now we clearly see the scalp hematoma, extraaxial hemorrhage, and calvarial fracture. This shows why reimaging studies degraded by artifacts is important. This will avoid missing gross injuries, as in this case, and unnecessary complications for the patient. In this case, the baby had a big swelling in the parietal region, hence the decision to reimage was made rather than worry about radiation burden in this infant. This patient presented with bilateral hearing loss for a long period of time. MRI of the internal auditory meatus was done. No acoustic neuroma is seen. Bilateral cochlear-vestibule and semicircular canals appear unremarkable. Do you see anything abnormal in these images? The 7th and 8th nerves appear unremarkable. No abnormal vascular loops are noted. The width of the internal auditory canal is prominent or patulous on both sides. This is congenital. Other tubular anatomical structures that can be patulous include the esophagus, eustachian tube, and urethra. The CT was done for abdominal pain and distension. No bowel obstruction or colitis is seen. Have you picked up the imaging finding? It's subtle, but it is there, and it's most likely the cause for abdominal pain. Along the anterior peritoneum, we see this circular area of fat stranding, which is characteristic of intraperitoneal focal fat necrosis. This is not an abscess, and this is not a collection. It's a spot diagnosis. Please read further about this pathology. They should not be confused with diverticulitis or epiploic appendicitis. I've published a case report on this 9 years ago. Please see the link in the description of this short video. This CT head was done for head injury. As you can see, there's acute scalp swelling in the left frontal region. There's another acute finding, which is usually missed. No extraaxial hemorrhage or subarachnoid hemorrhage. So what's the finding? Hopefully you have picked up the aneurysm in the region of the anterior communicating artery. This is the most common site of an aneurysm. This finding ideally should not be missed. Saccular-like aneurysm noted in all planes. This patient will require an intracranial angiogram with CT or MRI for further evaluation. This MRI whole spine was done to assess the age of a known fracture. It's clearly seen on sagittal images. There is a severe anterior wedge compression fracture of T8 vertebral body. Now, is this acute or chronic? T2, T1, and stir sequences will help us to come to a conclusion. In this case, it is low signal on all sequences, which makes this a chronic fracture. No spinal canal compromise is seen, and this fracture is stable. This patient had a CT head for headache. Have you spotted the abnormality? I've seen only 3 of these in the last 10 years. Most of the time, this is missed. In the left orbit, a tiny hyperdensity of 2 mm is seen. This small calcific focus is called a drusen. They are hyaline depositions in the region of the optic nerve disc. They can cause vision loss. Special thanks to Dr. Murphy, consultant radiologist, for this case contribution. This patient is having an MRI of the pituitary gland because of very high prolactin levels in the blood. On the coronal, a small nodule is seen along the left side of the pituitary gland, suggestive of a microadenoma. These are MRI images of the spine. There is a bright lesion seen in the vertebral body on T1 and T2 weighted images. This same lesion shows low signal on fat-suppressed sequences, which is characteristic of a hemangioma. These sagittal images clearly show a large mass lesion arising from the anterior pituitary gland. It causes significant mass effect on the pituitary stalk and optic chiasma. This patient has headache and vision loss. This is clearly a pituitary macroadenoma.